Okay, so this is a balloon retraining video that we use for bowel patients. Balloon retraining is really simple to use, but it can be intimidating. So I wanted to make this video to help you guys understand better how you can use a balloon for your patients with bowel problems. So who is appropriate to use a balloon in physical therapy or occupational therapy for? There's 4 types of patients. There's patients that have hyposensitive rectums. These people are often constipated, or they're going to the bathroom very infrequently with big, large, hard stools. So they're not able to feel when there's a poop in the rectum. People with hypersensitivity, their rectum might be overly sensitive, and so they have urgency, frequency, oftentimes loose stools, and they're going to the bathroom very frequently. Also paradoxical voiding patterns. So if someone's not able to get a stool out very well because they don't know how to coordinate a push, the balloon can be a great training tool. And last, anyone with weakness or fecal incontinence, we can play like tug of war with the balloon to strengthen the anal sphincters and the puborectalis. So we're going to go through balloon setup, a balloon spiel, and the 4 different types of training for these patients. So for setup, you're going to need a balloon catheter. These are sold by CMT. This is an older model. There's a newer model that you'll get if you're ordering them now, but this is the one that I've always used for training. And there should be a lure lock at the end of the balloon catheter that you're gonna then need a 60 ml syringe with a screw top, and you're gonna screw this in to the balloon. Now the lure lock always kind of confused me. I don't know if you want to get a close-up on this, Lovely. But with the lure lock, there's an open channel, and right now you'll see 3 arrows. That means where the arrow is are all the open channels. So if I were to draw air into the balloon or into the syringe, it'll come in through the open channel. But if I want the air to go into the balloon, I have to close this open channel. So this is the closed direction. So now if I push the air from the syringe, it's going to go into the balloon. And I can measure how much air is in there by using the milliliters on here. Now say I'm training and I want even more air in here. I could close the balloon. Now the balloon chamber is closed, and I opened the chamber between the syringe and the open port. I can grab some more air, and then I can close the open port again to continue to inflate the balloon. So it's often helpful to practice how this works before you use this for the first time. I usually do the treatment with water, and I've gotten water all over the place because I've screwed it up. So just FYI around how the lure lock works. When you have a patient, hopefully if you're reading this or watching this video, you have some written material that you can get from me. You can email me at Jennifer, JENNAFERMI@gmail.com, and I'll send you this little cheat sheet. But there's some patient education prior to use. I wrote out a little spiel for you. So it says, this balloon is attached to a syringe. It's going to be inserted into your rectum and filled with air or water. And this is going to make you feel like there's a stool in your rectum. So it's going to give you a little bit, it might give you an urge to have a bowel movement, but that's normal. And it can feel like a real urge, but you're not going to have a bowel movement on the table, I promise, right? It's just the balloon that's causing this. As we fill the balloon, you want to notice where the first urge, where the first sensory feeling comes from, like how many milliliters of air or water are in the rectum at the time of the first urge. And write that down, right? So if it's like 15 milliliters, that person might have a hypersensitive rectum. If it's 90 milliliters, that person might have a hyposensitive rectum. And so the average is about maybe 20 to 30 for a first urge, and then an urge to defecate around 50 to 90, so a little bit bigger range there. So this might help us understand the messages the rectum is giving you and help guide your treatment. Do you have any questions before we start? And so again, I just write in here that it's normal for patients to have feelings like they're gonna poop, but they won't because the balloon is in the way, right? They're not gonna be able to do that. So we can help patients with comfort by keeping a blue chuck underneath them, by draping them well with the towel or a sheet, and then providing them wet wipes for cleanup afterward. Now, another trick that I forgot to bring in the room today, but if you're using a balloon on a patient, and it might be really nice for extra cleanup if you put a condom or even an ultrasound probe cover over the balloon before inserting it, because then that makes cleanup really easy. You can just throw away the cover. Now, it says in the literature for these balloons that you must throw them away. You definitely cannot use them between patients, but many providers do use them outside of recommended practice for the same patient. So whether or not your clinical policy will allow for that is up to you and your organization. But if you're going to reuse this for the same patient, it makes for easier cleanup if you put a condom or an ultrasound probe cover over the balloon. Okay, so we're ready to get started. We have our patient here, and typically the patient's going to be on their side. So that's going to be, we're going to pretend that that's on their side. And remember, the balloon is going rectally, although with our pelvic model, it'll have to be kind of in this strange space that's neither rectum or vagina, right? So I'm going to say to my patient, okay, I'm ready to insert the balloon. Do I have your consent for this treatment? And they'll say yes. So I'll take the lubricant and I'm going to smear lubricant all over the balloon. And notice that I kind of wrapped up the balloon so that the pointy part of the catheter is going to be what's going into their rectum. Not just like I'm trying to get this balloon to go in there. So you might try that. That might be helpful for you to kind of wrap up the balloon around the catheter. And then we're going to insert this. And you want to make sure that it's actually in the rectum. So remember that the anal canal is about 3 centimeters in length. And so you're gauging, like, I'm just going to keep the pelvis like this. You're gauging about 3 centimeters past where the balloon ends. Okay, so that will be about where the balloon is going. Now, I said I'd like to use water because water gives a little bit more awareness for people because it's cold. It's colder than their body temperature, and it's heavy. So it's heavier like a stool. And then if we practice defecation with this person, that heaviness will assist us with gravity. So I have 60 mLs of water, and I'm going to screw this into the jack here. And then I'm going to make sure that that open area is closed. So all of the water is then going into the balloon. So remember, I want to know when the first urge hits. So I'm going to say, okay, you're going to feel the water going into the balloon. It'll probably feel cold. And you'll probably feel the unraveling of the balloon because I kind of wrapped it up to put it in there. So it's going to unravel. So most people, the first like 15 to 20 mLs might be feeling the coolness of the water. They might feel the unfurling of the balloon, but they're not feeling any kind of urge. And so about 30 to 40 mLs, they're like, oh, I feel something. Okay, that's pressure, right? I feel the pressure maybe. And then normally you can get up to 90 mLs before someone really feels an urge to defecate. Might even be 110 or 120. I never put more than 2 full syringes of air or water into the balloon, okay? So say this person is feeling, it has a hyposensitive rectum. I want to fill the balloon up until the person feels sensory threshold. Okay, I feel it, I feel pressure. So say that's 90, for example. So then what I'll do is I'll write down, okay, 90 is where they feel it. And then we're gonna play a sensory game. So I'll hold the syringe at 90 and I'll take 10 or 20 milliliters of water out of the syringe. And I'll say, this is less than 90. And then I'll go back to 90. I'll say, this is 90. And then I'll push more, 10 to 20 more milliliters of fluid in. I say, this is more than 90. So this is more. And so the person really has to attune to what they're feeling in their rectum, right? Like, who pays attention to what you're feeling in your rectum? Nobody, except like once again. So then I'll start at 90. I'll say, okay, this is baseline. Now tell me if I've moved it more or less. And I'll either take water out or I'll put water in. I won't tell them. And they have to attune to really what they're feeling. Now, usually they can feel a little bit more of a stretch sensation when you go to more, but they won't feel much when you take the air or the water out. So nothing is out, is less, where something is more, typically is how I cue this patient. And so we'll play that game with 90 being the midpoint. Then I'll back them down to 80 as the midpoint. And I'll say, okay, now can you tell what is more and what is less? And every session, I'm gonna see if their sensory threshold starts to decrease through this sensory biofeedback. So I played more or less games, basically, with the hyposensitive rectum to help them attenuate to the sensations of rectal filling. Now, what if this person has a hypersensitive rectum and I'm only at 30 mLs and this person is like, oh no, I feel like I have to go to the bathroom? Well, prior to this balloon training, you would have taught this patient some urge suppression techniques. And so this is where the urge suppression techniques come in handy. We want to retrain the rectum to be able to have a higher threshold of stretch before it sends the signals of defecation or urgency. So I would take this person up to 30 where they feel some urge and I'll say, okay, now I want you to relax. I want you to do some deep breathing. Maybe tighten the anal sphincter and hold for 30 to 60 seconds. And we're going to try to inhibit the urge that you're feeling. And so they're able to do that. And they practiced what we taught them. The urge decreased. So I'm going to give them a rest. I'm going to bring them down to 20. I'm going to hold it here at 20, give them a little rest. Now we might go to 35. Oh, I feel the urge. Okay, we're going to pause here. You're going to do your inhibition techniques. And when the urge passes, we'll give them a rest. We'll give them a rest at 30. And now we're going to go up to 40. And they're going to feel urgency. We'll do the inhibition techniques. And then slowly over time and repetition, we're building a higher sensory threshold for this person. And so they're able to get to 50 or 60 before they feel urgency. And they're also equipped with skillfulness around allowing the rectum to fill and not just running to the bathroom every time they feel a small urge. Very similar to bladder retraining, right, for urgency. Okay, now we're going to talk about what we do for fecal or gas incontinence or someone with a very weak sphincter. So what I would do for that person is fill them up probably to a good 50 or 60 mLs. And just to save my hands, I'm not gonna be using the syringe. I'm just going to close the balloon, so no air or water can get out of the balloon. And for this person, what I'm doing is I'm telling them to squeeze and hold the balloon inside of them while I try to pull the balloon out. So it's easier for this person to start with a bigger balloon because that's going to be easier to hold in their rectum. So I'm going to say, okay, pucker, 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 I'm pulling. And I can modify how strong I'm pulling, I can modify how long I'm pulling, and I can modify how many repetitions I'll pull for depending on this person's functional abilities. But basically we're playing tug of war. And I might do a 10-second hold for 10 reps. And then I might make it a little harder by taking some air or water out. So now I'm going to take 10 milliliters out. I think I am. Oh well, no water's coming out. Not sure why. And then I'll hold the balloon. And then I'm going to pull tug of war again with a smaller balloon. And then maybe the next time I do it, I do an even smaller balloon. Now most of my patients, so that's how you would strength train with the balloon. The last thing we're going to do is retrain expulsion. And this is such a helpful technique for people that are having trouble coordinating the mechanism, the mechanics of having a bowel movement. Now I do have a portable commode that's over in the corner here that I use for just this purpose. At the end of the video, I can show you how I set it up for easy cleanup. But I forgot to do that, so here we are. If a person is defecatory training, the standard number for a successful balloon defecation is a 50 to 60 ml balloon evacuated in 1 minute or less. So that would be a passing test on anal manometry. And I usually start with a 30 milliliter balloon for someone that's having problems. So they have 30 milliliters of water inside of their pelvis, and they're going to sit on the commode. And what I do is I have the tube of the catheter coming out in front of them. So they're sitting on the commode like this. And I leave the room and I say, I give them a squatty potty, I set them up on the commode, I say, I'm going to give you a minute. If you can get the balloon out in under a minute, great. If not, I'm going to come in and coach you and help you. So if they can pop it right out on their own, and I've trained them, obviously, I'm telling them what to do, but sometimes it's just easier for people to do this without you staring at them. Sometimes not. Sometimes it's okay for you to stay in the room. So you got to gauge your patient. So I'm telling them, big belly, hard belly, push down with your abdomen, push out with your abdomen, keep your pelvic floor relaxed. If they can pop the balloon out at 30, then next time we're going to do 40. And the next time we'll do 50. If they can't do it at 30, then I come in the room and I give them some help with the syringe. So I'm going to pull it a little bit and then coach them how to push. And then the balloon comes out. Okay, so start with a lower balloon volume and then progress higher. If they absolutely can't get anything out, then you just let the water out of the balloon and pull it out, which is what you can do if you're not doing defecation training for any of the other patients that we talked about. So you would drain the balloon of air or water and you would pull the deflated balloon out of the anus, out of the rectum. I've also seen patients practice defecatory techniques on their side, where they're laying on their side for the training. So on their side is where they try the defecation maneuver, which is fine if you don't have a portable commode, but I strongly recommend a portable commode because it's a more functional position and you're going to have your patient against gravity. So let's look quickly at the commode setup and then we'll talk through cleanup. So I have a portable commode that I just can fold down and it goes in the corner of my room. I'm going to sneak right behind you. And what I normally do is I have 2 pillowcases and a blue chuck. And the blue chuck would go underneath. I don't think I have any chucks in here right now, so I'm just going to show you with a towel. So I would put the blue chuck like this, and then I put 2 pillowcases here, so nobody's booty has to touch anything. And then the patient would sit like this. And then when they poop out the balloon, it would go into the blue chuck. And it would be like that. So then what I would do, and actually normally I take off the syringe first. So just make sure that the balloon is blocked, and I would take this off prior to them pooping it out. And then of course I have my gloves on, and I'm going to do cleanup. If I had a condom or an ultrasound probe over the balloon, then it's pretty easy. Grab some toilet paper towel. I would pick this up. I would turn it inside out, the probe cover, and put that in the trash. And then I'd get soap on my hands, and I would scrub the balloon real good and keep it inflated if it's already inflated. And then I would grab my fanny cloth and I would clean the balloon with the fanny cloth. This is if I'm going to use it for the same person. Clean the balloon. And then I wrap it in a couple of paper towels. I forgot to empty the water. Let me empty the water. I like milking a cow. So I get all the water out, clean it real good, and then I wrap it along with the syringe in some paper towel, and I have a Ziploc baggie that I put the patient's name on, and everything goes into the plastic bag with their name on it. Again, I just want to be clear that manufacturer recommends not using it, or like says, don't use it, only use it once and then throw it away. But these are pretty expensive. So again, follow your own facility's guidelines around that. Okay, so that's it.